of the Department of Human Genetics and the University of Michigan Genetic Counseling Program, I'm really excited to welcome all of you, both here in person as well as our 20 participants who are joining us by Zoom, to the 13th Annual Diane Baker Alumni Lecture. Today, we're going to be honoring Julie Culver, a 1994 graduate of the University of Michigan Genetic Counseling Program. However, before we get to Julie, I also wanted to take a moment to recognize Diane Baker and welcome her back to Ann Arbor today. We're so glad that you could join us again for this annual event. Diane's career at Michigan spanned over 25 years. And during that time, she founded our genetic counseling program and served as its first director. In addition to her role as an educator and leader, she provided genetic counseling in pediatric genetics. She administered the state's newborn screening program. She coordinated outreach clinics in Northern Michigan and provided outreach to local teachers and students. And I was actually looking through some old pictures from that this morning, and it was pretty fun. Lots of whirly ball pictures. So Diane's impact extended beyond the University of Michigan and beyond the state of Michigan, as she served in leadership positions in all of the national societies related to genetics, including our National Society of Genetic Counselors. She also co-edited the first textbook in genetic counseling and was importantly involved in the 2008 passage of the Genetic Information Non-Discrimination Act, which remains a really important part of the counseling that we provide to patients. Since leaving Ann Arbor, Diane has contributed to multiple nonprofit organizations, including the Genetic Alliance, Friends of Patients of the NIH, to name just a few of them. Most recently, she's partnering with her alma mater, Sarah Lawrence, to help them envision a genomics institute to meet the biotech workforce needs. And so thank you again for coming. Everyone who's ever been lucky enough to interact with Diane, including Julie and myself, are struck by Diane's generosity, kindness, and genuine curiosity. When we initiated this award 13 years ago, our goal was to identify members of our alumni community whose professional activities have honored Diane's legacy. And this year, we are thrilled to honor and welcome Julie Culver back to Ann Arbor. This is particularly special for me, as Julie was one of my classmates. Like many of us, Julie was deeply and positively influenced by Diane. Julie came to graduate school at the University of Michigan after earning her BA in molecular and cell biology from UC Berkeley in 1993. This is making me and you feel very old. Together with our classmates, pictured here, Carol Rubin and Teresa Brady, Julie and I persevered through the same courseworks that many of you are working your way through right now: 541, 542, 544, student seminar, clinical rotations, and counseling skills classes. The bonds that we made through graduate school remain really strong today, and the four of us continue to travel like we were students, sharing hotel rooms whenever we are in the same town, including last week in Nashville, when Julie and I were roommates together with Carol. After graduating from the genetic counseling program in 1994, Julie has spent her career working in the field of cancer genetics. She began at the University of Washington, where she provided clinical care and contributed to several important NCI and NHGRI funded studies related to the integration of cancer genetics into primary care. A decade later, in 2004, Julie made a move south, closer to home, to the City of Hope, where she served as the Assistant Director of the Cancer Screening and Prevention Program Network, a high-volume cancer genetics clinic, and continued her contributions into important research efforts. Of note, while Julie was at the City of Hope, she also helped develop and continues to serve as a faculty on the City of Hope's 10-week intensive course in cancer risk assessment, which, for those of us who work in the cancer genetics field, we recognize that this is really an outstanding model for the provision of educational modules to non-genetics provider. And it really exemplifies Julie's commitment to educational efforts. In 2012, Julie then made the move from the City of Hope to the Keck Medical Center at USC, where she remains today. At USC, Julie continues her clinical work as the Director of Genetic Counseling and her educational efforts as a mentor and supervisor to genetic counseling students from the UC Irvine program, UCLA, the Keck Graduate Institute, and when we're lucky enough, University of Michigan students as well. Julie also remains active in important clinical research, as we'll hear more about today, incorporating the values of justice, ethics, diversity, and inclusion in much of her work, in her current work. Julie's ongoing involvement in clinical care, research activities, and education really characterized as a role model for our current students and alumni, and is a really ideal candidate for this award. So I couldn't be more excited to congratulate my classmate, Julie Culver, and welcome her to the stage.
So lovely.
All right.
Okay, can everyone hear me okay? All right, so thank you so much for inviting me. And thank you for such a wonderful introduction, Monica. And I'm really thrilled to be here. I'm a big Michigan supporter. I had such a wonderful time here, and it's great to be back after 28 years. This is my first time back to Ann Arbor. So thank you for the warm welcome. And it's been so nice to talk to so many of you today, the students, faculty. And I'm very excited about Michigan in general because of their success in football. I'm also very excited about USC. And so here they are together, Michigan and USC, and maybe they'll be seeing each other, probably not in the Rose Bowl because they're both incredibly good this year. So maybe somewhere else. So we'll see. Okay, so see if I can advance the slides. Okay, so this is the class of 1994, and I didn't know if you all knew that Monica and I were classmates, but our class was 4 back then, and we were very close. We got teased for always hanging out in a unit of 4, and everybody thought we were very cute because we always hung out together, and we still always hang out together. As Monica said, we always enjoy seeing each other and rooming together at the conferences. And Monica and I especially spent a lot of time together studying and working really hard at our graduate studies together. So we got to be very good friends. And there's us at graduation. We look exactly the same, I'd say, Monica. All right, so then here's us with some of the faculty, and here you could see us, including my mentors, Jane Chouette, Wendy Ullman, Diane Baker, Doreen Markle. Obviously, these are leaders in the field. They authored the Guide to Genetic Counseling, first edition, copyright 1998. Diane was the most wonderful role model for me, teaching me genetics, but even more importantly, professional skills that I value even to this day. I think we were all kind of in awe of Diane. We were, you know, we learned how to interact with patients. We learned how to interact professionally. We learned how to maintain our composure. All these things we learned from you, Diane. So thank you so much. It's wonderful to see you. And she, you know, really helped me put my first foot forward when I graduated. I was very young, and I just really appreciated all that support. And so that's why, part of why I'm so incredibly honored to receive this award. So thank you. So here are the 3 directors. Each of them have served and benefited this program so much. Diane for 22 years, and Bev for 20, and now Monica, maybe 20 more. But you've been with the program already so long, and both of you, all 3 of you have given so much. So it's just wonderful to have you all here and have the chance to spend time with you all. This was the Michigan reunion from Nashville from just 2 weeks ago. And we had the opportunity to meet there to celebrate the program, and most notably the accomplishments of Bev, who has been given so much to the program over the years. We celebrated her with fantastic speeches and cookies, got to meet the second-year students, which was a great experience. And I just also really want to acknowledge the efforts of Monica as she advances in her new role as the program director. She's very well deserving after being with the program for 18 years and supporting countless students. And as a University of Michigan genetic counselor, former undergraduate student, graduate student at Michigan, you know, she's really been the glue really that kept the alumni together. And so all of you as students, as you move on and graduate, you'll appreciate that so much, between the newsletters, parties, acknowledgements, emails about research from former alum. You can see that she really is the glue that holds the program together and keeps the alumni feeling so connected. And she brought those cookies in her suitcase, I will say. One thing that Monica also does that also really helps me feel connected as a Michigan alum is that she's gotten Michigan genetic counseling program shirts, like t-shirts and sweatshirts, and I really enjoy wearing those on game days. So she's perfectly suited for the position as director. So congratulations up to that for that, Monica. So, all right. And there's some more pictures from the reunion. You already saw that in Monica's slide, but that was really great because it was a networking opportunity, and there was even a surprise appearance by Diane Baker herself, who I'd not seen in at least 15 to 20 years. So let me tell you a little bit about my professional background. So I know that many of you as students are looking to see which direction you're going to go, whether you're planning on going into clinical care, or into research, teaching. And so I wanted to just share a little bit about my career trajectory, just so you have a sense of possible directions and things you may be interested in looking out for. So I got my bachelor's degree from UC Berkeley and came straight through, got my master's here at Michigan and graduated in December 1994. Later, I was able to take some additional coursework in epidemiology and biostatistics at University of Washington. So I didn't get a degree, but I did end up learning some valuable statistics skills and research skills, which was really valuable. That's always a possibility for you. Even after you graduate, you can always improve, always learn. So I started working in cancer genetics. As Monica said, my first cancer job was at University of Washington and the Fred Hutchinson Cancer Research Center. And I had no background in cancer, so I didn't take any cancer courses. There wasn't a cancer course. I'd only seen one patient who had a history of cancer in her family in the adult medical genetics clinic. I saw that patient with Wendy Ullman. And I really had no experience, but there was this job available, and there was a big job shortage when we graduated. There weren't that many jobs available at all. So I wanted to live in Seattle, moved to Seattle for this job, and it was a research job. It was funded by the ELSI, the Ethical, Legal, and Social Implications branch of the Human Genome Project. And it was looking at what would be the public health impact of the upcoming availability of BRCA testing. So it would potentially have a huge public health impact because breast cancer is such a common disease. So what would that mean for people with breast cancer, for their family members? Would people misinterpret that the test, having a positive test, would mean whether they would get breast cancer or not? Would everybody think if they had breast cancer in the family, they should get that test? So the studies were looking at how to provide counseling to people with a family history and looking at different models for doing that, whether it's with genetic counseling, psychosocial group counseling, and looking to see the effect of counseling in a randomized trial. And so this was some of the first randomized trials of genetic counseling that had been done, and still are some of the best ones that have been done to this date. And one of the great things about that is that I got to learn about a whole new area, and you as students are going to find that after you graduate, after you get your master's and pass your boards, you may land in a job where you have to learn completely new information, and genetics is changing daily, as we know. And so there's so much technology to learn, which is why our jobs are so incredibly interesting, but they're also changing very quickly. So I worked in these sorts of roles within research for almost 10 years, and then moved south, mostly for family reasons, to Southern California, where I worked at City of Hope in cancer genetics, still had a foot in research, always been very interested in decision-making, post-genetic testing, and the psychological reaction to genetic testing. And then in 2012, I moved to my current role at USC, where I'm part of the USC Norris Cancer Center, which is a comprehensive cancer center. There's also, it's part of the Keck Medical Center of USC, where it's a university medical center. And there, I'm now the director of genetic counseling, and also do research. About 30% of my effort is in research, and most of what I'll be talking about today is research. So, but that's just a little background about me. So what I hope to do today is to talk a little bit about counseling in diverse populations, to talk about the existing disparities surrounding genetic counseling in diverse populations, to talk about research efforts regarding ethnic disparities associated with hereditary cancer genetic testing and genomic characterization, and also to suggest some concrete strategies for genetic counselors working with underserved patients and patients from diverse backgrounds. So some of this is probably not new information to you, but there is a wide oh, sorry, if I can just go back a slide. I just want to acknowledge my coworker and very close collaborator, Chadite Ricker. And I know some of you have met her, but she's a genetic counselor that works in a similar role to me at USC, but she works at the Los Angeles County Hospital. So a lot of the work we do together, we do side by side, and we meet every week, we strategize every week, and we case conference every week. So I just want to mention her because she gave me some of the slides for this talk, and also much of the research you'll see her name in the publications. We're on many projects. All right. Oops. Okay. So, all right. So there are wide disparities in access to and completion of genetic testing for cancer. And some of this is magnified for many reasons, for low literacy, low socioeconomic status, and patients of ethnic minorities. And there's so many factors to low utilization, but for many patients, it's simply lack of access to genetic counseling. And so this is an important and modifiable factor. So one of the very important points for racial and ethnic minorities is that they are cared for at safety net hospitals with limited genetic services. So not all people of all backgrounds have the opportunity to go to an academic medical center somewhere like this at the University of Michigan. So because of that, various approaches have to be developed that are feasible and sustainable for serving diverse populations, to increase uptake, and much attention has to be paid to language and literacy and the other needs of diverse clinical populations. So one of the major issues that we have in general is that there's not very many Spanish-speaking genetic counselors. So all of these are really important considerations to think about when thinking about more access to genetic counseling, more access to genetic testing. So I want to tell you a little bit about the setting that I'm in, which is in Los Angeles County. I know that there's actually several of the first-year students that are from California. So this could potentially be relevant to other areas of California, Texas, many other states as well. So we have more than 10 million inhabitants in the 4,000 square miles. It's a very ethnically diverse population. About half is Hispanic or Latino, Latinx. Most of that, 70%, is from Mexico. There's about 20% Central American and 10% other. And the white non-Hispanic makes up about 26%. We also have a very sizable Asian population and somewhat smaller, but still significant Black or African American population. There's 34% of the county is foreign-born, and only 46% of the population speak English only at home. So there are many other languages spoken. And where I work is in the upper right. It's where you see the fall colors on the tree. We don't get too much fall colors, but I thought I'd just put that up there so we get a little bit of that in LA. And so you can see where that is. That's at the USC Norris Comprehensive Cancer Hospital. And there's 4 genetic counselors, me being one of them. And then across the street, literally 1,000 steps away, is the LAC plus USC Medical Center, which is the safety net hospital for Los Angeles County, and one of them, it's the main one. And there are 5 Spanish-speaking genetic counselors. That number of genetic counselors has increased from 1 to 5 since 2019. And that is in large support due to grant funding and some funding from LA County and from the Cancer Center. So it used to be that it was a 9-month wait for cancer genetic counseling appointment, or longer sometimes, depending if they had cancer or no cancer. And now it's gradually coming down slowly as the new genetic counselors are actually 3 of them started this year. So we're still kind of working on the backlog. This is a table from a study where we recruited at both sites, but it gives you a good sense of the population of the LAC USC Cancer Hospital, or sorry, not Cancer Hospital, but the LAC USC Hospital. And you could see here, I could use this. There we go. Okay. So you could see the primary language being Spanish for about 65% of the population there. The Hispanic component being 76%, and the educational level 62% with high school or less education. So you could see the population there is pretty unique, and and definitely is the underserved county population that is what we're trying to improve. We're trying to improve access. So we did a study of a 25 or 28 gene panel, and we did this in 2,000 patients. This was done actually at 3 sites. It was both USC hospitals and also Stanford, and they had to have a 2.5% probability of a mutation or meet standard genetic testing criteria. And this paper was looking at some of the psychosocial outcomes in panel testing. And so all the participants had pre and post genetic counseling, and they completed something called the MICRA scale, which is administered at 3 months after they get their results back, and it measures distress, uncertainty, and positive experiences. And so we also grouped people's genetics. We looked to see if the results would vary based on their genetic test results, and we grouped people into genetic testing categories: a high-risk pathogenic variant, a moderate risk pathogenic variant, VUS, or negative. So this gives you a sense of the numbers here. So there were 2,000 that started in the study, and then the results are shown in this. Let's see if I can, oops. Still kind of getting used to this, sorry. So we had 1,264 who responded to the 3-month follow-up, 93 with a high-risk pathogenic variant, 70 with a moderate risk, 443 with the VUS, and 650 with negative. And so what we found was that if you look at how they responded to questions on the MICRA and looked at the average response. So this essentially was each statement, like how often do you feel sad, or how often do you feel confused or uncertain? So basically the higher the number, the worse they felt on average. So this chart is a little bit, it's a little bit hard to understand, so I'll just spend a few moments. So this is a box plot where it shows the median is this dark line here. So that's the middle, or the middle response. And then you could see the range of responses, right? And the box is where 50% of the participants in that category lie. So the shading, where these little tiny stripes show the number of people, or the percent of the patients in that category falling into that area. So here you could see half of the participants in the high risk rarely, or almost, maybe sometimes, were veering into this sort of negative space where they would feel negative about their genetic test. And you could see there's almost like this kind of a step ladder, right? Where the moderate risk pathogenic variant don't feel quite as bad, but we're basically in the green zone for all of them, right? And then the VUS and the negative are almost never having some of these negative feelings about their genetic testing. But one thing that was encouraging is that 92% of all participants never, rarely, or only sometimes reacted negatively to their results. So people were generally doing pretty well after their panel testing. Now, there was somewhat higher uncertainty and distress among carriers of high and moderate risk pathogenic variants, which kind of makes sense. And there was lower levels identified among those with a VUS or negative. And the VUS and negative really didn't differ from each other too much. I'm going to show you a little bit more data on the next slide. This was a multivariate analysis, and you can see that if you look at this, shows the scores for this. The first is the total MICRA score, and it shows the median, the mean, medium, and range, and then whether there's any significant difference. So I'll just kind of point you to the significant difference area. That what it's showing is that when you compare the high risk pathogenic variant to the negative, there is a significant difference in the MICRA score, which you can kind of see from that step ladder with what I was showing in the previous slide. Now, when you look at the uncertainty, well, there's a little bit of a significance here between VUS and negative. So having a VUS leads to just a little bit higher levels of uncertainty. If you look at distress, there's a slightly different, slightly more distress among high risk and moderate risk compared to the negative. And if you look at positive experiences, turns out well, there's less positive experiences if you have a high-risk pathogenic variant. And that just kind of makes sense because, you know, if you have a BRCA mutation, you know, there are some issues there. So essentially, it's showing generally things are in the right direction. People are reacting well to their genetic test results, but there are some differences based on the result. Now, what about looking at it by race, ethnicity, education level? Well, what it shows here is that if somebody has more education, they essentially have a better reaction to their genetic test result. If they have cancer history, they have a worse reaction to their genetic test result. And I already explained about the test result itself, but there were no significant differences based on race, ethnicity, which we thought was pretty interesting, that there was no significant, and also the individual sex did not make a difference as well. So essentially we found that those essentially higher total microscores among those affected with cancer and high school or less, but other factors, race, ethnicity, and even language spoken, and clinic site, whether they're at County or at Stanford or at USC Norris, did not significantly affect the total microscore. Another study that was done in the same population was looking at family communication in high-risk families. And this was specifically focused on the 3-month follow-up and genetic test disclosure in 136 pathogenic variant carriers. And in this population, we had quite a bit of diversity with 46% non-Hispanic white, 41% Hispanic, 10% Asian. So less than half white, essentially. And at that point, at 3 months post genetic test results, 99% had shared genetic test results with someone, and 96% had shared them with a family member. So we also found that Hispanic respondents were less likely to have told a healthcare provider about their results than non-Hispanic whites. So it was a pretty significant 29% versus 68%. Asian respondents were less likely than non-Hispanic whites to encourage family members to undergo genetic testing. But when they told them, they're more likely to do it. So maybe they're being very selective about who they told. And so basically the summary was that at 3 months post genetic testing, the communication of results was very high among the people who were testing positive. And 30% actually reported that by that point, a family member had even undergone genetic testing. So we were pleased that things had moved along so far, even in the first 3 months. Another area that I'm very interested in is genetic testing for breast cancer. And there are several studies that have showed that there are racial disparities among women with breast cancer, with non-Hispanic whites more likely to be referred for genetic counseling and genetic testing. But once they get to genetic counseling, there is no significant difference in the uptake of testing. So testing is popular among people once they can hear about it. So an area that I'm really interested in is offering genetic testing to all women with breast cancer. And my hope is that in addition to providing a valuable clinical service that can help people to make informed healthcare decisions, that could actually increase access and mitigate some referral biases that can exacerbate those racial and ethnic disparities. So this was a study that I had recently done with some of my colleagues at USC, including Chadate and Jacob Como, Emmeline Chang, who are the genetic counselors that I work with. We use the premise that all women should be offered genetic testing for breast cancer. All women with breast cancer should be offered genetic testing because it has been recommended by the American Society of Breast Surgeons back in 2019. And we actually have a multidisciplinary clinic where we can see patients with a new diagnosis and offer them genetic testing. And we hypothesize that breast cancer patients are highly interested in undergoing genetic testing and that the results can be obtained urgently for surgical decision-making. So we had a population of 138 newly diagnosed cases that were attending the multidisciplinary clinic, and 95% of them accepted the offer to have genetic counseling, and 93% accepted genetic testing. So we found 15 which was 12% did carry a pathogenic mutation, including 8 or 7% with a mutation in a breast cancer gene. And one of the great parts about this is we were able to deliver the results really quickly with the mean time to stat genetic test results of only median only 8 days. And for stat patients undergoing surgery, we checked their medical record and 98% of them were able to get the results before their date of surgery. So this was incredible help. And we've developed some really good relationships with our breast surgeons, and they really appreciate the service, and the patients really appreciate it too. And so what we concluded is that when integrated into a multidisciplinary clinic, that genetic testing can successfully be incorporated into treatment planning. Now, this doesn't solve the problem of access to genetic counseling, right? So that's another issue. So we are constantly thinking of ways, and I think some of you as students should be thinking of ways, how can we have all patients get access to testing, even if they can't get access to pre-test counseling? And what can you do as a genetic counselor to make sure that their service, their clinical service, is comprehensive? Maybe you won't be able to meet with everybody before their test, but maybe you can provide some materials to help them get to where they at least understand the test, at least provide consent for testing, and then counsel them with the results perhaps. So thinking about alternative service delivery models is going to be more and more important. And now our study did note a somewhat higher uptake of genetic testing among Hispanic and Asian women than among non-Hispanic whites. So we had, of the people who declined, which is obviously very few because it's very hard to measure declining when 93% want genetic testing, but 75% of the decliners were white, 25 were Asian, and none were Hispanic, like every Hispanic person. So essentially, the numbers are way too small to do to have a meaningful statistical analysis. So we, obviously need to do further research to see if the uptake would differ, but generally the uptake is very, very high among all groups. So next I wanted to talk about a big exciting grant that we were able to get at USC. This was part of the Moonshot Initiative, and we were able to do a grant proposal. It took 2 tries. We started proposing this in 2019. We didn't get funded the first time. We tried again in 2020, got funded in 2021. And this is a large study looking at participant engagement in genomic characterization. And there were 5 sites that were funded, all looking at diverse populations or rare tumor types. So USC is one of the sites, and we were funded to study participant engagement for germline and somatic genetic testing among Hispanic and Latino individuals. So we're recruiting 500 Hispanic and Latino individuals with colorectal cancer. The bulk of the recruitment is going to come from the county hospital. I am involved in the participant engagement unit, and what my role is to make sure that participants are entering the study with appropriate consent materials, education. They do not all get pre-test genetic counseling because we're trying to model this after the real world. Not everybody's going to always be able to have genetic counseling, but what we are doing is we are making sure that participants are aware of what's happening, getting access to consent materials, getting materials in both English and Spanish, and having trained consent specialists. And the consent specialists are able to explain the study. And our main goal pre-test is to explain the difference between germline and somatic testing. So when they get the results back, they know that germline testing is about heredity and somatic testing is about cancer treatment. They get the results from their oncologist, and every case is reviewed in tumor board. And the majority of patients will get genetic counseling either because of their family history, because of their genetic test results, or because they request genetic counseling. So everybody in the study can get genetic counseling if they want to. But we're trying to set up a model whereby patients can get this information, get through the system. They don't necessarily have to meet with a genetic counseling. But we are looking at the fact people who do and don't get it. One of the things we're really interested in is what the study participants can give back to us as researchers so that we can continually improve and make the study more accessible and more understandable for all of the participants. So what we're looking at is not just participant engagement, but engagement optimization. So we're conducting focus groups and we're conducting interviews with participants to understand their baseline knowledge and then what they learned from the study and what they need from their informed consent process. So this just shows a few more details about the study. So the participants get pre-test education, informed consent, results opt-in preferences. Then of course they get blood drawn. They actually have to have 5 tubes of blood, and their genetic test their germline test goes to Invitae, and their somatic test goes to Exact Sciences, which is a somatic CLIA lab in Arizona. And once their results come back, then they're discussed at tumor board. And our first colorectal cancer patient who came through had this amazing RNA fusion that is completely targetable, and he has metastatic cancer to the liver. So it's one possibility for his treatment, could be this RNA fusion. So everybody was really jazzed up about that. And so we have consented about 20 participants so far. So I don't have any results yet, but we will be presenting this hopefully at some upcoming meetings, maybe at NSGC or CGA, and hopefully we'll be able to tell you more about it then. Okay, so, and this is from a video. We have a consent video that our patients watch. It's in English and in Spanish, and our study name is called Enlace, which is a kind of a long acronym that translates to Confronting Cancer as a Community. And so we're trying to use participant engagement to really help this be meaningful for our participants. Okay, another area of research that is being led by my colleague, Chadate Ricker, is relating to this CDKN2A variant. If anybody has a cancer genetics practice and sees any sizable number of Hispanic and Latino individuals, you will be as equally perplexed by this variant as we are. CDKN2A is a gene that is associated with a high risk of melanoma and pancreatic cancer. And it is extremely challenging for genetic counseling because it is considered a VUS by some labs, like Myriad. It is considered likely pathogenic by other labs, like Ambry and Invitae. So depending on where your patient is tested, you will have a different interpretation of that variant. In our practice, at Norris and at County combined, we do case conferencing together. We probably see this variant once a month. So it's a problem. And it is not just a problem for us. It is a problem at many other centers. So Chadate has started a collaboration between us, UT Southwestern, UCSF, UCLA, and Stanford, because we all see this variant and are all equally baffled by it. And our concern is that people who have this variant are not all getting the correct counseling about what to do about their screening, right? Do they need screening for melanoma? Do they need screening for pancreatic cancer? So some people are being told to do it and might be over screening, and some people told not to do it. It might be under screening based on what their report says. So it's a big challenge. So the goal is to collect as many families as possible so that a pedigree analysis can be done to see what kind of cancer is actually occurring in the family. And with a large enough population, a large enough number of families, and wonderful genetic counselor pedigrees, we're able to get accurate information and pull all of this together. And our hypothesis is actually that there's going to be a higher rate of pancreatic cancer in these families, but perhaps not melanoma. And the reason could be that skin tone can affect melanoma risk. So if somebody is fair-skinned and they get sunburns, they have a higher risk of melanoma. And depending on the amount of European versus Native Indigenous American ancestry a Hispanic person has, their skin tone can be somewhat different, which could affect their melanoma risk. So we'll see. Stay tuned on that one. In the meantime, watch out for this variant. Okay. All right, next is a study where this is again, Chadate Ricker, my partner in crime. She is a master's trained genetic counselor. She just got an R01. So she's kind of a hero. And this is, again, trying to increase access to genetic testing in underserved patients. And it's using a multilingual conversational agent. So this is, again, another means of service delivery and trying to expand access. And we are working with a couple of investigators at USC, including Karen Lerman, who is our cancer center director at the USC Norris Comprehensive Cancer Center. She is a research psychologist. So she loves doing research with genetic counselors. So we have a wonderful team, and we have Jennifer Sway, who is an implementation scientist in healthcare. So essentially what we're trying to do is to give access to people who may not have access, perhaps in our county population and also in rural communities. We have a site in New York that's participating in a rural community. And the study is trying to develop and evaluate a Spanish and English speaking animated computer character to provide genetic education to help overcome barriers to obtaining testing at the two clinical sites, LEC plus USC and University of Rochester. So, so we have a underserved safety net population, primarily Spanish speaking, and we have a rural population. And the diseases that are going to be include cancers that it's just absolute that they need genetic testing, like pancreatic cancer, ovarian cancer, triple negative breast cancer. So they're all meet criteria. So there's no question about should they not get genetic testing. It's more about consent, right? It's most about them understanding the test they're getting, wanting to do that. Okay, so many of you are familiar with the idea that there's a higher percentage of VUS among non-Western Europeans. This is a really old slide. It's from 2009 data from Myriad Genetics. And as you can see, the patients with the highest VUS rate up here are going to be your Middle Eastern, Asian, African, and then you see Western European, which is the kind of a yellowish color at the bottom. So, and then all together, well, you can see they probably have mostly all Western European, very few of the other ones, because all patients is almost completely overlapping the Western European. So you can see that the rates have gone down between 2002 and 2006. This is BRCA testing. The rates of VUS have gone down, but there's more VUSs. And the reason is lack of data, right? It's just that these labs haven't seen every person of every ethnic background as many times as they have Western European. So what the problem that results from this is that you might have a genetic test report that looks like this one, where you've got, like this patient actually has a positive, but she has a positive in RAD51D, which is a gene related to ovarian and breast cancer. And then she has 4 variants of uncertain significance. This happens to be a Filipino patient. So it's like, okay, so all of this uncertainty, what does it mean? There could be a positive buried within there, right? All those variants. So it could be that she's not hearing and getting to learn about management that she needs, right? Or it could be that she walks away feeling somewhat more confused or uncertain. I showed you earlier that people with VUS have more of a tendency to uncertainty. So it could just mean that she's either confused or not getting the counseling that she needs. So now this is again another gap, and it has implications for providing equitable counseling, and it's a continued disparity. So this is from our research, again, Chadate and I working together on a project where this is our initial results from panel testing. And you could see here in the final column that there is of patients with 2 or more VUSs, that it is more likely to have 2 or more VUSs if you are Hispanic, Black, or Asian. Or more than one race. So yeah, so this, again, a burden that we see in our own population. So we wanted to look at that in a unique way. And we wanted to look at this in something called Orion, which is a multi-site collaboration. USC is one of the sites. We have about 6,000 participants, but there's many centers around, about 19 cancer centers around the country participating. And it's an industry funded study actually that is essentially paying for genomic characterization, germline and somatic. It's not CLIA, so patients don't get the results back, but they do ask for data extraction for the medical record, how patients respond to chemo, and they're looking at targeted treatments to see if the genomic mutation in their tumor or germline correlates to the success of the cancer treatment. So essentially that's what that study is. And we've been recruiting for this since 2016. And we are looking at genetic ancestry in the population. So now there is, and I don't know if this has been covered in the program, so apologies if it has. But essentially there are 4 or 5 major parental or quote unquote trunk populations that gave rise to the existing populations. So of course there's single nucleotide polymorphisms or SNP data that can be used to see the percentage somebody is of European, African, East Asian, South Asian, or American Indian. And this has been done by some of my coworkers at USC, David Craig and Mackenzie Postle in the USC Department of Translational Genomics. And we, of course, have this very diverse population of people who have had genetic counseling at USC. And so this allows us to look to see what is the probability of receiving a clinical genetic test with a variant of uncertain significance with a VUS, and whether that's proportional to the percentage of Indigenous American, African, or Asian genetic ancestry. So we know that self-reported ancestry can be correlated with VUS, but what about genetic ancestry? And one of the things that is very interesting about the Hispanic population is that someone could call themselves Hispanic because that's a self-identified trait. People speak Spanish, they're from Latin American countries, they call themselves Hispanic, but their percentage of European ancestry could be 99%. Their percentage of Ashkenazi Jewish ancestry could be 99%. So people who have Hispanic ancestry can also be 99% Indigenous, right? And they speak Spanish because they're Indigenous ancestry from perhaps Mexico. So if they have a higher percentage of an Indigenous ancestry, do they have a higher VUS rate? So just because the term Hispanic doesn't really tell you the percentage of European versus other ancestry. So, and we have a population, as I said, is very diverse. So we can study this question. So that is our next project, is looking at our data. We don't have the results yet, but hopefully at an upcoming meeting, I'll share that with you. Okay, so now I wanted to leave you with some advice as genetic counseling students and kind of how to handle this and how to work with patients. And when you think about your roles and your future jobs and how to work with patients of diverse and underserved background. And some of this could be if you're working with patients with perhaps low education, or maybe non-English speaking, what are some of the things to think about and look out for? So there have been several publications looking at what are some of the genetic counseling issues that come up. And this talks about specifically cancer risk counseling in diverse populations. So genetic counselors may provide too much information, use complex terms, potentially providing information about concepts in a difficult way. And patients may not necessarily see all this as personally relevant. And so this could result in an unintentional inhibition of patients engaging and asking questions if they're kind of being lectured to, let's say. So the challenge is that to meet people at their level. So what are some things you can do? First of all, avoiding too much information, focusing on the key messages. What do they need to know? What are the key things that a patient needs to know and do? And so what I do and what I work with students, genetic counseling interns, and maybe we're going into a session with an interpreter. Maybe it's a Korean speaking patient who has cancer. And what does this person need to know? What is the key things? If I can walk out of that session and if I have conveyed to them that, and they've conveyed their consent for testing, and I've hopefully gotten as much as I can family history, I will have had a success. They don't necessarily need to understand every detail. They don't need to see pictures of chromosomes. So to do that, I encourage the students to think through what are the key things, that they need to leave from that session. Now, of course, using plain language, thinking about the terms you use, and also can ask the patients what they perceive with the discussion was about and whether ask them to teach the information back to you. Now, working with interpreters. Last summer, I had a wonderful genetic counseling student who had never worked with an interpreter before. And the session did not go that well. So she didn't pause enough. She was using the words, the language she was using was a little bit too complex. So at a certain point, I was like, okay, let me take it from here. And then I finished the session, but then we talked about it. And then within like 2 days, she had another session with the interpreter and like she completely changed. So these are all the things that we talked about and all the things she actually was able to do by the second visit with an interpreter. So, so first explaining to the interpreter, you know, why are we here? What's this about? So the interpreter can understand, because when we talk about genetics and launch right in, they may not be fully ready. We ask the patient if they have questions up front. We say, hey, stop me if it doesn't make sense. One thing I really try to do with interpreters is to be very concise and to speak in really short sentences. And while they're interpreting what I just said, I'm already thinking of the next short sentence and how to break it down. And so basically just those discrete pieces and thinking through ahead of time, what are the things I need to get across? Avoiding jargon. We have so many terms in genetics, and it's difficult for interpreters sometimes. Defining words, like new words, checking with the patient. If you have materials in the patient's language that you could like have them look at and follow along while you're talking, and you have it in English and they have it in their language, and you can both be looking at the same paper, they'll comprehend so much more. So trying to get those materials in advance. And then of course, if you can work with the same interpreter, all the better. And then I always also, if they come with a family member, I ask them how they feel about me giving the results to the family member if they want that. And 9 times out of 10, they're going to say, oh, please call my family member and tell them the results to tell me. But sometimes they say, no, call me with the results with the interpreter. So just a clear plan of what they want. And people will tell you what they want if you ask them. Now, one thing is many of you may have taken Spanish in high school, and you may have some limited Spanish skills. So this was presented, some of you may have seen this at NSGC. This was a podium presentation by Becca Wagner, who's part of my team. This was her graduate student thesis project. And she did a study where she looked at 118 genetic counselors with varying levels of Spanish proficiency. So there's varying levels. I'm not going to go through the details, but it's everywhere from basic to excellent. And you can see among her 118, she had a sampling of all of those levels. And the participants observed 7 minutes of a pre-recorded prenatal genetic counseling visit with a Spanish interpreter. And there were 20 translation errors embedded in the videos. So the question is, as somebody with some basic Spanish, can you hear the errors of the interpreter? And can you find those errors? Okay. And so the goal of the study was to determine the level of Spanish proficiency needed to detect 80% of those errors. So that's what she found. There was obviously a correlation between finding the errors. So if 80% of the errors could be found on average by people who had good, very good, or excellent Spanish skills. Basic and fair, not so much, but at least they found some. And some of those errors can be extremely important for genetic counseling. Let's say you're talking about cancer genetic counseling. If you know the difference between the word uterus, ovary, and cervix, that's amazing, because even I, who took French in high school, can understand if someone said, you know, matriz or utero instead of ovarios. So like, I'm like, wait, what'd you just say? So like, I'll call them on it, and then, okay, that makes a big difference. Like if you're talking about BRCA, knowing the difference between ovarian and uterine is really important, or if you're talking about Lynch, right? So, okay. So basically in conclusion, you know, obviously the effect of cancer genetic testing and subsequent effects on family can differ based on the education, race, ethnicity, and cancer status. Universal testing can reduce disparities, whether it's in a breast cancer clinic or part of a research study on colorectal cancer. A diverse clinic population can allow for unique genetic counseling research projects. So keep that in mind in your settings. And if you're interested in getting into research, trying to find diverse populations, which are so interesting because we know so little. And you as a genetic counselor have the opportunity to identify and reduce disparities. So with that, I just want to say thank you for being such a great audience and listening so attentively, and for a wonderful day. And you all really rolled out the red carpet here for me today. So I feel very fortunate. And I also want to thank my team. So we have my group here at USC, which includes, there's 4 of us that work at Norris and 5 at County. And this was a picture we took for Genetic Counselor Awareness Day, which was a few weeks ago. And so we are quite the growing and expanding team. So just wanted to thank them for everything they do as well. So that's it. Thank you.
Very interested in your too much information. I'm a geneticist and I've dealt with a lot of research across different countries. And I think I'm loud enough for everyone. And this too much information was a big issue when we tried to use a consent in China versus America, where they just shook their head to our 15 pages or whatever that are that basically mandated here by our IRB, and we had to really work on compromising. So my question is really, is part of the too much information that there are certain things you're legally obligated to say when you're consenting someone that is really unnecessary information for them and from their point of view, but that is legally mandated? Or where do you think the cuts could be?
Well, so that could be different from a research perspective versus a clinical perspective. For research, we have a short form in something like 20 different languages. So when we do consent patients for research, there's a very short, like a 1-page form that they can sign. So we work with research, we can kind of get around it that way. That's for patients who don't speak English or Spanish, because we do have consent in Spanish. But clinically, it's much more of a judgment call. I don't think there's necessarily a legal sort of minimum threshold. I think it's going to almost differ by the person, you're counseling. So as a genetic counselor, I think one has to kind of walk in knowing, what are the key points that this person absolutely needs to get from this session. And maybe it's going to be different for the person, and different because some people are going to be looking at it in a very different way than others. And it's different if they have cancer, if they don't have cancer, and of course, different in prenatal and other settings as well. So I think that's a challenge clinically. Any other questions?
Thank you so much. It was an amazing time. I was wondering about your first study that you talked about, the microevaluation and the difference between patients reporting stress and anxiety after the test. And there was no significant difference for ethnic and racial minorities. Do you think it might be because they are housed in LA County, which has lots of resources for racial minorities? And if this was done in a more rural area where there's less resources for these patients to seek help, there might be a difference in how they react to the test results?
Well, first thing, and I think I did say that everybody had pre and post counseling, right? So that helps, of course, greatly, right? Because it would be very interesting to see people who got those results and didn't have genetic counseling. So if their reaction could be different, and I would guess that it would be. But I think the reason that education played a role is because we have a very economically diverse population, right? So we have a lot of Hispanic and Asian individuals who are seen at the University Medical Center, right? And they have insurance, and then we have another population doesn't have insurance, right? And of course, we know that education and income are so tightly linked, right? So when you think about the reason that maybe race or ethnicity wasn't as big of a deal, it was because so many of the people of different races are potentially in one population being underserved versus another population of the employed, better off economically. So the reaction to genetic test results was really education based, right? It wasn't so much their race. Does that make sense?
Yes. Thank you.
Yeah. So that.
Hey, Julie, thanks for a great overview of the areas you've been working in and kind of trying to pull together maybe what Margaret was asking and what Satara just asked. In our conversation earlier today, you talked about the fact that the practice group at the community hospital is now a much more diverse practice group. And I noticed in the authors on the paper, many of which whom I know, you had a large group of GCs, both from the Stanford area and then from USC. I'm wondering if you all looked at the impact of the providers, since you highlighted that you got pre and post-test education, and what that impact is, especially in light of the fact that the profession is trying so hard to think about the impact of culturally concordant versus culturally discordant counseling. So could you talk about that a little bit?
Yeah, I'd be glad to have one. So that study, when you saw the author group, and so there was only one genetic counselor in the county who did all of the counseling, which was checked. She was the only person that has been there that whole time. And so, so it's a challenge because there's only one person at that one site. And so when you think about the group we have now, there's now 5 bilingual, bicultural, Spanish-speaking counselors at county, but that study was completed in 2016. So they had all the counseling back in 2016. So a lot's changed since then. So we haven't looked at by counselor. When some of the things we are looking in our new study where we're doing colorectal cancer testing in Hispanic and Latino individuals. There we could potentially look by counselor. We could look by language because we have a little bit more going on. I'm seeing some of the patients that are English speaking, and then there's 2 other counselors that are Spanish speaking who are going to be seeing the county patients and our Spanish speaking patients. So there will be a little bit more of an opportunity to that. All right, well, I think that's the end of our time.
Thank you so much, Julie.